Good day, my name is Thomas Zeller from the University Heart Center Freiburg-Bad Krozingen in Germany. Today I'm talking about drug-coated balloons, drug-eluting stents, wire interwoven or covered stents, a segmentalize approach to SFA and popliteal artery disease. These are my potential disclosures. The main focus of this talk is on complex femoropopliteal lesions, including long task lesions. What we know from a network meta-analysis of randomized controlled trials of endovascular treatment of femoropopliteal lesions, mainly task A and B lesions, is that paclitaxel coated balloons or eluting stents perform the best up to 1 year with regard to restenosis rate and freedom from reintervention. This is an overview about freedom from clinical driven reintervention rate for task A and B lesions, comparing bare metal stents with drug-eluting stents and the IN.PACT Admiral DCB. It seems that by trend at least drug-eluting devices perform better than bare metal stents, even if we have to realize that bare metal stents do perform also very good, with a freedom from reintervention rate of about 80% if third generation devices are used. The lowest freedom from reintervention rate was found for the second generation live stent. Let's go into the details of drug-coated balloons for long lesions. The complex lesion subcohort analysis of the IN.PACT global study included 20% of in-stent restenotic lesions, 70% of total occlusions, and the mean lesion length was 28%. Impressively, freedom from reintervention rate was 93%. However, what is noted in all DCB studies so far is that primary patency is decreasing with lesion length, and also TLR rate is increasing. And this is in particular true for lesions longer than 25 centimeters, as shown again in the long lesion imaging cohort of the IN.PACT global study. Primary patency at the end of the window for lesions longer than 25 centimeters was 64% as compared to almost 90% for lesions with a length up to 20 centimeters. It's obvious that with increasing lesion length, the bailout stent rate is increasing. However, worth to note again, based on the IN.PACT global study, lesions that performed good with DCB angioplasty only as compared to bailout stented lesions perform not significantly different up to 2 years, and as recently demonstrated, even up to 4 years. The key question is, with this increasing lesion length and need for bailout stent implantation, do we need a full metal jacket or is focal stent implantation sufficient? A recently published study comparing spot stenting with full lesion coverage shows better clinical and technical outcome for the spot stenting cohort with regard to primary patency and freedom from reintervention rate. Alternatively, as compared to stents, we can even implant short scaffold, so-called tags. The TOBA 3 study performed drug-coated balloon angioplasty with the IN.PACT Admiral balloon followed by tag implantation in case of dissection. The outcome at 1 year was impressive with a freedom from reintervention of 97% for standard lesions, and even for long lesions it was 96.8%. Primary patency for standard lesions was 85% as compared to 89% for the long lesion subcohort. As an alternative to the tags, short stents, the so-called Multi-LOC multiple stent device, can be used. This device consists of 6 stents with a length of 13 millimeters with various diameters. In the LOCOMOTIVE study, comparing drug-coated balloon and bare balloon angioplasty followed by the mini stent implantation showed promising results up to 12 months with a freedom from reintervention of about 90% and a primary patency rate of 85%. What about drug-eluting stents for long lesions? This is 1 year freedom from TLR and primary patency for the long lesion cohort of the ZILVERPTX single arm study. Primary patency 78%, freedom from reintervention 80%. A direct comparison of the ZILVERPTX stent with DCB shows by trend a better outcome at 3 years with regard to primary patency for the ZILVERPTX stent. The randomized controlled ZILVERPASS study comparing ZILVERPTX stent placement with prosthetic graft placement showed similar primary patency and freedom from reintervention at 2 years, with a slight trend towards better outcome for the ZILVERPTX drug-eluting stent. Just recently, the Eluvia stent was introduced and compared with the ZILVERPTX stent within the Imperial study, and by trend, the primary patency of this particular device was even superior at 2 years as compared to the ZILVERPTX stent. The wireband endoprosthesis was compared already a couple of years ago with bare metal stent placement for complex lesions. This is the outcome of freedom from reintervention at 2 years, showing a trend towards better outcome for the wireband as compared to bare metal stent. If you look to long lesions, the difference is much more pronounced. Even based on the smaller number of patients, this difference was not significant. For long lesions with a lesion length of 26 centimeters, primary patency at 1 year was 67%, freedom from reintervention was 78%. The wireband was also compared with bypass graft, in this study with venous bypass graft. Primary patency was similar for both cohorts. If you look into the outcome for bare metal stents, the superior stent in particular showed excellent outcome with a freedom from reintervention rate of 94% at 3 years, and this was also true for calcified lesions. Lastly, the Biomimics 3-dimensional helical stent did show a superior outcome with regard to reintervention rate as compared to a straight stent, the live stent, with significant reduced reintervention rates. The Mimics 2 study, a single-arm study, could even show better outcome at 3 years, freedom from reintervention rate 89%. So in summary, which devices for which lesion? For short lesions, task A and B lesions, I recommend drug-coated balloon angioplasty with provisional stent placement and tacking. For more complex lesions, stents, bare metal stents like superior, drug-eluting stents and covered stents may be better than drug-coated balloon, and surgery is still an option for task D lesions. I thank you for your attention.